Good evening, everybody. My name is Matthew Jenkinson. I am chair of the Greater Manchester Local Eye Health Network, and I'm going to act as chair of this evening's webinar. Just a little bit of housekeeping to begin with respect to the CET points allocated to this webinar. And there is one CET point for optometrists, dispensing opticians, and therapeutic prescribers. And to be able to earn that CT point, there are just a couple of key points I would like to make. There will be a couple of polling questions at the beginning and end of the event. What I will ask you to do is answer 1, 2, or 3 to those questions within the Q&A box within the Zoom features. So you will need to stay on to the end of the webinar, so including the Q&As that we'll do right at the very end. And after the webinar, you will receive an email with a link to a short feedback survey. So you could please complete that survey as soon as possible so that your CET points can be issued. With respect to asking questions throughout the webinar, I mentioned the Q&A box a moment ago for the polling. So as you hover over your screen with your mouse, down at the bottom, you will have an option for Q&A. What we'll be doing is throughout the webinar, we'll be collating those questions together, and I will be posing any of those questions that have come up through Professor Sadiq's lecture, and I will post some of those questions to him right at the end. So please do put those in there, and we will bring that together as we move to the end of the event. I think I'd like to just spend a couple of minutes just talking a little bit about the background of this event. So this event was initially scoped to be something of a grander nature, looking at trying to bring together Greater Manchester Eye Health stakeholders in a multidisciplinary training event over a whole day. I felt as Greater Manchester Local Eye Health Network chair that what we needed to try and do was, as we work together more collaboratively, break down some of those perceived barriers between the individual disciplines, so ophthalmologists and optometrists and orthoptists and hospital versus community, just bring people together, an opportunity to network and understand what each of those roles were a little bit more. I think I'd just like to thank Scope for persisting with the idea of this event and allowing us to start a series of these tonight. Obviously, COVID hit and we were in a different position, had to switch to doing things virtually. I think I'd also say very well timed presentation with lots of areas in the Northwest and Greater Manchester who have now started delivering the COVID urgent eye care service in primary care, seeing primary care optometrists manning a lot of patients with urgent symptoms. And tonight's webinar will certainly go through some of the differential diagnoses that you may need to consider as you're managing those within primary care. So over to the lecture proper. So Professor Ahmed Sadiq is going to be giving you the lecture. So the background of Professor Sadiq, trained in London, working as a registrar and fellow then after training in Nottingham, prior to being appointed consultant ophthalmic surgeon, specialising in cataract and ocular plastics at Manchester Royal Eye Hospital in 1998. Professor Sadiq is a visiting professor at Liverpool John Moores University and has over 65 publications, so well versed in ophthalmology to be able to provide this lecture this evening. So I'm going to turn my camera off and mute and let Professor Sadiq run through the lectures. And so thank you very much, Professor Sadiq.
Good evening, everybody. Again, my thanks also go to Scope for arranging this. First of all, it's the polling slide that Matt just mentioned. So if I give you a little bit of time just to pop your answer into the Q&A box, please, and then we can carry on after that. And Matt, if you just let me know when that's happened, and then we can carry on.
Thanks, Professor Sadiq. I think a lot of people have found that, so I think we will let you continue as they continue to put their 1, 2, and 3 into that box.
Thank you, everybody. So this is the program for this evening. The first half is going to concentrate on the ophthalmic delivery in a community setting. And then I'll go on to managing the commoner conditions in ophthalmology, which is the dry eye and the blepharitis, and then also finish with some other diagnoses for red eye that you'll see quite commonly in ophthalmology and in primary care. So the first half is about delivering ophthalmology in the community, and that's really based on my own experience of community-based ophthalmology. I was involved in setting up one of the companies that delivers community-based ophthalmology in the UK. Started about 10 years ago, and I was with them until about a year or so ago. And I was involved with basically all aspects of the company, from the paperwork to delivery clinically. And the companies basically have to deliver what they're asked to by CCGs. CCGs being the clinical commissioning group who will provide ophthalmic care for their local population. And that's sort of the common mantra that the CCG wants, is they want to provide excellence in eye care. So they want a high quality of care, not just about quantity. They also want to deliver the care closer to patients' homes, so the patients don't have to travel very far. They also want patients seen very quickly, most of the time within 14 days, obviously. Very different from what happens in hospitals when patients can be waiting for a few months despite all the deadlines that we have. They also want a high level of safety, and the money is important for CCG, so they want to have all of this delivered in good value. It doesn't necessarily mean that they go for the cheapest always, because the other things have to be inbuilt into the system, but certainly they score value for money quite highly. So the reasons they want to manage patients close to home is it's easy for the patient and their carers to travel to the service in that case. They also want to keep patients in the community and only transfer them to hospitals when required, and that's usually for surgery or very complex conditions. Doing that also means it releases the burden on hospitals in the appointments they have to provide for things that can be for patients that can be seen in the community or in primary ophthalmic care. It reduces travel for everybody, so it's very good for the environment, so less driving to hospitals, less problem with car parking, and also less costs for patients when they do travel. And as Matt mentioned, they actually want to have a joined up model of care across the ophthalmology spectrum, so from the GP to the provider of primary care, which can be optometrists or ophthalmologists in a community setting, and then into the ophthalmologists in the hospital. So that should be integrated, so there's no loss of continuity of care for patients. So I'm just going through the kind of contracts that we've had, we've been asked to deliver around the country before. So often they always ask for a senior to lead the service, not necessarily to deliver the service, but a senior ophthalmologist to oversee what's happening and then to guarantee the quality control of what's happening to patients. They want patients to be seen and to have any tests done within the 2-week period often, so that would include whether they need to have visual fields, an OCT scan, etc. So that diagnostic is done often on the same day as their clinic visit, so it's all a one-stop service where possible. They're also quite keen to take patients out of hospital into the community where they have a chronic low-risk condition that can be managed out with the hospital. So things like ocular hypertension, controlled glaucoma, and other medical retina conditions that can be seen in a community setting, whether that's from a GP practice or optometry practice. Again, that releases appointments for the hospital clinics and reduces their general workload often. Now, companies nowadays that deliver this have to be very linked into the NHS IT system, and all referrals, virtually for all contracts nowadays, come through the e-referral system. So optometrists such as yourselves will make a referral into the ERS and go through to the provider, who then allocates appointments. They also want to have in each CCG area clinics in each of their localities, again, just to make things quicker for travel for patients, so they only have to travel maybe 10-15 minutes to the nearest delivery venue. They also want delivery venues to be easy to access with public transport, so often they're on main roads or near bus routes, so the patients without cars can access them as well. As well as delivering face-to-face care, often these contracts also contain an element of clinical advice and guidance, where just advice about patient management can be delivered without the patient having to be seen. Again, it's quicker for both the patient and the delivery service, because the patient doesn't have to be seen and they can be managed by the GP or by the optometrist with the correct advice. So that will often involve sending the referral in, and the triage person for the service emailing back or ringing back with the advice for that patient. So that does really speed things up quite a lot in certain conditions. So they do ask for an integrated pathway, and this is one such pathway where a patient is referred into the system. They're triaged by the provider of the service. So they triage into, first of all, whether the patient can be seen or not in the service, so they fulfill the criteria, how quickly they need to be seen, where they need to be seen, and if any diagnostics need to be done at the same time. So the patient's then booked in by the service for any diagnosis before they see a clinician, and then they see the clinician who takes a history, does the examination, and makes a diagnosis and a treatment plan. That treatment plan may include ongoing management for patients with chronic problems. A few patients will require onward referral just because there will be in the mix some patients that need secondary care or tertiary care involvement. And then the majority of patients will actually be discharged, although the primary care ophthalmology can carry on seeing follow-up patients with glaucoma or other conditions that do need to be seen at regular intervals. So that will be like an all-in pathway for patients, so coming in, being seen, and then leaving the system as well. So often contracts, they do give you a list of conditions, and it's not really cherry picking. They've chosen conditions that they would like to be seen to be managed in the community because they can be managed in the community, and secondly, it takes the patient out of the hospital system to free up the appointments in secondary and tertiary care. So if you know, the commonest ones are obviously ocular hypertension, where it involves the regular pressures and diagnostic tests. Controlled glaucoma, again, you're making sure the patient is controlled and not deteriorating. And if any of those conditions, if the OHD goes into glaucoma or their glaucoma is worsening, then there is a direct access back to further advice in secondary care. Dryes and blepharitis are always very, very common in very common conditions in the community, and they can very well be managed in primary care, whether it's with a GP or with optometry colleagues. Psoriasis is also quite common, and that can also be seen in clinic. With lid lesions, often it's making a diagnosis. If the triager thinks something may be cancerous or basal cell carcinoma, that goes straight to the hospital. But other lid lesions, they just want to make sure that it's a benign diagnosis. They may not necessarily cover surgery for that, but they just want a diagnosis where the patient and the GP referrer can be reassured that there's nothing cancerous or dangerous to worry about. Colleagues already see patients with flashes and floaters, so they are diagnosing posterior detachment. Age-related macular degeneration, a lot of our ophthalmologists now have OCT, which is great. So it's an ideal place to get an initial diagnosis, differentiate whether someone has got dry or wet AMD. And the wet AMDs can then go into a service that provides injections or whatever treatment that patient needs. It's also very useful for following up patients that have had injections and may be dry, so to make sure that they have no recurrence of their fluid. Also for nevi, where you want to have 6-monthly or yearly checks of a lesion to make sure it hasn't grown. And the other very useful diagnosis in primary care is the pre-assessment of cataracts. What a hospital service doesn't want is to have patients come into the system that then don't need to have cataract surgery. It's not really, I wouldn't say it's a waste, but certainly it's not a good use of their resources to see patients that don't need to be operated on. So if that initial pre-assessment of cataracts or pre-screening can be done by optometrists and only the patient sent in that requires surgery, that's actually good for the system and good for patients as well. Now, often community providers also deliver some minor operations. It's possible to do quite a lot, but this is a list of the kind of things that most contracts would ask for deliver. So the insertion of punctal plugs for patients with dry eyes. Again, it's very easy to train and to order the plugs so they can be inserted in a primary clinic. When doing minor operations, punctoplasty is relatively easily operation. It doesn't require much in the way of equipment, and it can be also performed without any major complications in the clinic. Syringing, of course, for patients with watery eyes or similar. Again, that's just done in the outpatient setting. The commonest minor operation for lumps and bumps is actually for a chalazion. Fewer CCGs are now funding chalazion operations, and if they do fund them, they often ask for an individual referral to bypass the fact that they can't have chalazions done on the NHS in a lot of places. But again, chalazion is very easy to do in the community. You just need a small amount of equipment and a service where if they have any problems, they can come back to it. Other things that are quite easy to do in primary care are little warts and sebaceous cysts, skin tags. Again, that is open to local rules. Some CCGs will allow that and others won't. So it's no matter having a list on the wall of what is allowed to be done in that area and what isn't. Trichitis is easy to remove lashes on the slit lamp and also to perform electrolysis in a minor operation setting. Then we get on to bigger eyelid operations. Generally, entropion repair can cause a lot of bleeding and require bipolar, so that's the bigger operations aren't really done in a community setting, but everting sutures are very easy to do without much bleeding. Just a couple of 2 or 3 sutures under local anesthetic, and then within 5 minutes the entropion is averted. They obviously have a higher rate of recurrence. And entropion repair with averted sutures may last perhaps 1, 2, 3 years. But still, it's very efficient for the patient to have it done quickly, perhaps as a one-stop service, and then have a comfortable life for a while. And of course, I've already spoken really about the pre-screening for cataract surgery before they go to the hospital. Now, community service can't be all encompassing because of the facilities. So often the facilities are smaller with fewer staff. The practitioner may be on their own as a lone worker, so they can't see every condition. And often these contracts do exclude children, patients under 16, and that's because of safeguarding issues, and also often there's no orthoptist with the service in the community. They usually exclude cancer patients because the service isn't set up for managing skin cancer. There is some possibility of having urgent conditions seen on the same day. Often services are asked to leave 1 or 2 slots free for urgent referrals, but the system often isn't geared to get the patient in during the opening hours of the service, so they usually need to be seen at the hospital. And the diabetic eye screening is done through a different contracting method, so that is usually out with or separate from the community provider. So often there are no orthoptists in the service, so children aren't seen. Complex cases, of course, that take a lot of time to sort of may require multidisciplinary review or extensive investigations. They're seen in the hospital as well. And malignancies obviously need to see often an MDT service. Patients that need urgent laser, so retinal tears or holes, are sent into the hospital and squint for the same reason, because they need to see an orthoptist. So these are often the commoner things that aren't seen in the community just because of complexity and the additional requirements for personnel. So I thought I'd go on to some general conditions now. This is the sort of the middle bit of the talk. The commoner conditions that can be managed very, very effectively in primary care, whether that's with GP colleagues or optometry colleagues. So I have based this on a sort of a symptomatic approach. So this is Very common presentation. Often patients have no symptoms, but they present with a red eye, something a bit like this. This is a mild version. This is actually my own eye from a few years ago. I went to London on a train and came back later in the evening. My wife said to me, I've got a subconjunctival hemorrhage. I was totally unaware of it, totally painless. And that settled over 2-3 days. Doesn't really matter about the extent. Obviously, that slide on the left just looks worse because it's a bigger hemorrhage. It'll last a few days longer than my own one on the right-hand side. But again, it's just a matter of reassuring the patient that it's just blood. Very similar to what I normally say, it's just like the blood bruise that you have, but it's when a bruise is on the hand or arm, it's covered by skin, looks greeny blue rather than red, but on the eye, it's covered by clear skin of the eye, the conjunctivitis, which is why it looks worse and it's why it's red. The only time you might want to do something else is if they have a recurrent hemorrhage, perhaps have their blood pressure taken by their GP. I've only ever found one patient in my career that had a significant pathology, which is a sort of leukemia or something, to account for their hemorrhages. So often it's just a benign thing. Certainly when I started my junior job, no one ever explained to me what to do with them. I used to give them the chloromphenical drops, so they don't need anything at all. And later on, even if they attend A&E, you can just reassure them when they enter the door that there's nothing to worry about. So again, very common. Often it tends to happen overnight, and it's there when they wake up. So there must be something to do with sort of turning over in bed or some trauma from that. So the commonest thing of all that you'll be referred from GPs for an opinion is patient with this kind of presentation, with irritable eyes, foreign body sensation. Have they got sand in the eye or sandpaper? The eye feeling a bit dry, difficult to open, feeling heavy. Often they're worse in the evening. The eye can be a bit red as well at times. Usually don't have any discharge from the eye, and the symptoms are often worse in summer and winter time, and they can get recurrent conjunctivitis. So this is, in a way, the commonest diagnosis in ophthalmology, which is that of a dry eye. So the dryness gives them the irritation, the foreign body sensation. The eyes feel heavy to open just because there's no lubrication to move the eyelid over the cornea. The worse in the evenings because the dryness, the eye has been opened during daytime and the dryness is worse by the evenings. And the red just because the eye is a little bit upset, saying it's dry to them. Worse in some winter and summer. Summer, of course, because the atmosphere is warmer, and winter is because the heating's on in the house and in the car, and that dries out the atmosphere. Very common in taxi drivers in wintertime because they have the car heater on pretty much all the time. Hopefully you've heard of DEWS, which is the dry eye workshop, and this is the original slide from the first meeting in 2007, and they have an updated version from just a few years ago. And they basically split the dry eye into two, the aqueous deficient and the evaporative ones. Again, this is something you can look at a later stage, but in essence, they have the two causes: the evaporative, which is the rapid evaporation of the tear film because of a tear lipid deficiency. And this is very common in patients with Meibomianitis and Blepharitis. And the other kind, which is the aqueous deficiency, which is not producing enough aqueous tears. And that can be just due to the involution of dry eyes, or perhaps a little related to systemic conditions such as rheumatoid or SLE, where their dry eye is worse than otherwise. So the mainstay of treatment is drops and more drops. And often patients that are still symptomatic is because they don't use enough. And I say to patients, the more you use, the better it is. There's no side effects, so use as much as you need to stay comfortable, and then a little bit more. So often I'll start patients on drops every 1 to 2 hours and ask them to modify them until they find the frequency that's right for them. I also say to them that every day is a little bit different, so you need to have different amounts of lubrication going in on different days, depending on the climate that's around you. I was given a little bit of advice about the difference between drops and gel and ointment. So drops are great for the daytime. They don't last too long, 15-20 minutes perhaps, but they do give a better vision. Gel lasts for perhaps 2 to 3 hours with a slight smear, so that can be used with more severe dry eyes in the daytime. And ointment we generally tend to reserve for nighttime. It causes a lot of blurring and smeariness, but it does last 6 to 7 hours often. The other thing I say to patients is there's 100 different varieties of dry eye lubrication and drops around, and that means that there's no one type that's suited for everybody. So I say it takes, try 4 or 5 different ones and carry on with the one that suits you best. We have much greater amount of preservative-free drops available now, so we have fewer problems with preservative allergy for patients that have to put drops in very, very frequently. So in dry eye, antibiotics aren't really a mainstay of treatment. They may work temporarily if someone's got an ongoing conjunctivitis secondarily, but the mainstay of treatment is lubricants and lots of them, and preservative-free if they have to use them very frequently. Heat masks I'll talk about again shortly under blepharitis, but they're very useful for increasing the production or the expression of tears from the Meibomian glands. Occasionally tetracycline antibiotics for patients with associated blepharitis, and some other treatments in long term, so vitamins such as omega-3. Again, patients are not keen to pay too much if they have dry eyes, so don't really like to pay extra for vitamins. If someone has severe dry eyes, anti-inflammatory agents or other ancillary things such as cyclosporine and steroids, and again that will mainly be delivered by a hospital in people that have got very severe dry eyes with corneal complications. But certainly the top is what can be delivered very, very easily in any primary ophthalmology service. So Secretion is obviously just in a way that a more severe version of dry eyes, and often it's associated with some systemic disorders such as the rheumatoid, etc. Now, dry eye patients are obviously quite hard to manage because they, like some of the patients, they do expect us to be able to cure them, and then we can't. So I say to them, this is a chronic condition that you have to treat for yourself. So as well as the drops and the hot compressors and the heat masks that we mentioned before, the other kind of lifestyle changes that can be helpful to them is having a humidifier, perhaps in the kitchen or the bedroom, that will wet the air for them, so it makes the eyes less dry. When they're concentrating, sort of reading on a computer or on a mobile phone, most people have a reduced blink rate. So I remind them to try and think about blinking more often. Resting between activities is also, or during activities, is very useful, because especially if they're doing intensive concentration. So if they're reading or on a computer, again, where the blink rate may be just 4 or 5 times a minute instead of every few seconds, if they rest from the activity and start blinking again, that will also help their dry eyes. Punctal plugs are really useful for increasing the wetting of the eye. The great thing about them is they're very easy to put in. If the patient finds it a little bit uncomfortable, which is unusual, or if they get too watery, then they can be easily removed. The minus side is that they can come out, especially if someone rubs the corner of the eye, but they're very easy to put in again, and often we'll go for the next size up if a previous plug has helped and has come out. And I've mentioned the omega-3 and the cyclosporine earlier on. So it is a sort of a lifestyle disorder. All these things can help in someone that has dry eyes and they're still symptomatic despite having their lubrication. So moving on to the other very common thing, these are the common presenting systems of someone with blepharitis. So irritable eye, dry eye, perhaps with some discharge. Then I've sort of split this into two, which is the anterior blepharitis and then the Meibomianitis cases, because they are a little bit different in their management. So the lid margin disease can be split into two, which is the anterior and the posterior. So this is really underdiagnosed. That's because often these patients will initially present to a GP who are not familiar with the diagnosis. If they go to see optometrist, of course, they can be seen in the slit lamp, and then blepharitis is diagnosed. So I call it akin to a patient having dandruff along the eyelids or in the hair. So you have these sort of flaky skin that tends to drop into the eye and cause the irritation, as well as inflammation of the eyelashes. Different causes. Again, these can be managed by a patient, but they need to be aware of why they may get blepharitis and then deal with the underlying cause. The important thing just to say to patients with blepharitis is that, again, we can't cure them. So they expect to see us have a drop or a tablet that will take away the condition, but obviously that's not the case. We can make various suggestions to make them more comfortable, to ameliorate the condition, but we can't get rid of it for them. Often it's cyclical. They'll have episodes of blepharitis where they're worse, more symptomatic, and then it'll settle down, then recur, then settle down. And the mainstay of treatment for patients with this anterior blepharitis or subarachnoid blepharitis is the hot compresses. I always recommend the microwavable bag rather than hot flannel. Microwavable bag is more consistent in its temperature. You get a higher temperature, stays hot for longer, whereas the hot flannels get cold very quickly. Obviously, we no longer use shampoo to clean the lids with, but we have now specialist lid hygiene wipes, which are great, single use, so they can use one wipe for four eyelids on a daily basis and then throw that away. And of course, lubricants for the symptomatic part of blepharitis, the dry eye segment. So a bit more difficult to manage is the posterior blepharitis, or the Meibomianitis, which is an inflammation of the Meibomian glands. They have very oily secretions, or the secretions can solidify at the Meibomian gland orifice. The Meibomianitis accumulates on the lid edges, and it's also a great place for bacterial overgrowth because they like to have a warm, wet, inflamed surface to breed on. And then the bacteria make these toxins which can go into the eye, cause the symptoms of the redness, the soreness, the stinging. So it is a very common diagnosis, and there's different ways of diagnosing it. You can do tear testing, tear breakup time, staining, but the best way is obviously by physical examination with a slit lamp and looking at the Meibomian glands. Newer methods are interferometry and osmolarity. So those two pictures show you the difference in the Meibomian glands. You can see them, the Meibomian gland coming along the entirety, along the height of the upper lid. And in the older patients, they've lost about 2/3 of their Meibomian glands, so much fewer, and also the ones that are left are shortened and scarred. So obviously we don't always have access to those, and certainly I don't have access to those new methods of diagnosis. So it's just a matter of looking at the eyelid on the slit lamp. And there's a number of things that you can see, and this slide has the 6 changes that you see, but I tend to concentrate on lid margin erythema. Again, that's a sign of inflammation with new vessels coming over the lid margin. Looking at the Meibomian gland orifices to see whether they're open, whether they're closed, whether they have blockage, and also looking at what the Meibomian glands produce. So often that involves giving the lid a little squeeze to see what the contents are like, whether they're clear or coloured. Again, these pictures on the right, top right, will show you the different kind of orifices that you see when you look at a slit lamp. Often patients with the chronic blepharitis will have notching of the lid margin. That's from scarring from the inflammation, and that's a sign they've had a long-standing Meibomianitis. So the bottom right shows some Meibomian glands that are very stenotic and even scarred off. There is, like everything else, a grading system for what's coming out of the Meibomian gland. So this is what happens when you give a squeeze, and I'm sure we've seen all of these types in our patients. So you can have the grade 1, the inspissated Meibomian contents, the coloured ones, grade 2, and then this sort of clear liquid, which is the grade 3. If they're all scarred, then you get nothing coming out of them at all. So these patients will have much worse dry eyes because they're not having the Meibomian, the Meibomian, go into their tears. Overall, it's quite a very difficult treatment to manage. Again, one is because the patient is expecting a cure when there isn't a cure. It's also very dependent on the patient treating themselves. So like any chronic condition, patients do treat themselves when they're symptomatic or when they're worse, and as they improve, then they tend to knock off their treatment. And that's known in all chronic conditions, really. And then they'll restart the treatment. But in that interim, of course, the inflammation is still ongoing, even though their symptoms may be better. And that's the time when they get scarring of Meibomian glands, the notching, etc. So again, the mainstay of treatment is the symptomatic control, which is artificial tears. Often we tend to use hyaluronic acid once now or lipid replacement because the Meibomian gland patients have got a reduced tear breakup time. The problem is, as I just mentioned, is the compliance with treatment, not using their lubrication or not using enough, and also patients stopping their treatment, especially as they get a little bit better. But again, this is just the symptomatic improvement rather than treating the underlying condition. So I use a mask myself because I do get recurrent Meibomianitis, and I've had, I think now, 4 Meibomian cysts myself. So I was asked them to buy a heat mask that's heated up in the microwave, just because it's easy to do, and you can get this consistent temperature of about 42 degrees, which is very useful for warming up the Meibomian glands, releasing these secretions and turning them from solid to a bit more liquid. It's generally suggested that they perform manual expression of the Meibomian gland contents after the heat treatment. It's certainly not easy to do, especially when they're inflamed. It can be a little bit tender. There are mechanical methods to do this, but obviously they do incur expense. And of course, eyelid scrubs. Again, this picture isn't great. It shows a gauze rather than the proprietary ones that we would normally suggest patients to use nowadays. So we've certainly gone away from hot compressors with a flannel, which is I tend to ask patients just to go straight for the microwave bag. Lots of different varieties out there, and I've got 2 or 3 different ones myself, which I use. I also have some that when I go away, I have these portable ones that heat up just for single use overnight. Same with the cleaners. Again, much a greater variety of cleaning or hygiene wipes available nowadays. I tend to ask patients to do their lid hygiene once a day, whether it's in the evening or morning, whichever suits the patient's routine. And they can use the wipes, one for all 4 eyelids, or put a little bit of the solution onto their finger and rub in. And the latest ones, of course, don't need to be washed off afterwards. They can just leave the solution on to help control the inflammation. And the other thing that's very useful is hypochlorous acid. This is a natural product on the eyelids to help fight against bacteria, viral fungi. And now it's available as a spray form so that it can enhance the local protection that's already there. So some of the other kind of treatments we give for patients with Meibomianitis, Meibomian gland disease, are systemic antibiotics. This controls the inflammation of the lid and also controls the bacterial infestation of the Meibomianitis. Now, often we give a tablet once a day for a long-term basis, perhaps 3 months initially, and then for recurrences of once a day for about a month. Topical antibiotics help for the same reason. Steroids would tend to reserve for very severe cases, again, just because of the risks of steroid use in patients, thinking they can go back to steroids whenever they have an exacerbation rather than just using them when they really have to. The cyclosporine is also quite useful for these patients, as are vitamin supplements such as omega-3, and of course, the mainstay still being lubrication. So this is a challenging condition to treat just because it's chronic. Patients don't do the treatment on a continuing basis and tend to stop it when they are improved. The other reason Meibomianitis is important is because it does have some long-term complications that can affect the cornea. So the top picture shows a very common thing, which is marginal keratitis. So you have these infiltrates or inflammations of the cornea associated with blood vessel ingrowth. That's very responsive to a short course of mild topical steroids healed within a few days. But over time, having recurrent marginal keratitis can lead to vessel ingrowth and thinning of the cornea. Often these patients also have rosacea. So if you look at the rest of the face, you can see the inflamed skin on the forehead, the nose, the cheeks, the lip area, and the chin. So I often ask them to look in the mirror and say that what's happening to their nose or their forehead is exactly what the eyelids are looking like. So they have an idea that the eyelids is red and inflamed. Now this may need some help from a dermatologist or from a GP to treat the rosacea. Okay, so this the final part of it really is sort of other common conditions that you may be asked to see in primary care, which don't have to go to hospital, except for two which I've put in just to make sure that we can differentiate them. So this is something that we see quite commonly, often in spring and summertime. So a patient presents with a sudden onset of swelling, usually often of one lid. The eyes close, and of course they're very worried about it. Again, if you take their history, they may have been gardening or had an insect bite. So this is very typical of an acute allergy. So when you do open the eye, you can see the Conjuncti Iritis very chymosed and red, but the actual cornea is clear and the vision is normal. And this is something that settles by itself. A single episode of acute allergy I often don't treat. It'll settle over 48 hours or so, and then it'll all go back to normal. The patient needs to be aware that if it happens again, then less worried second time around. But of course, we see a lot of patients that have got a chronic allergy. So these patients always present with an itch. Itch is the symptom that is only associated with allergy, really. So you don't really get itch in the Blepharitis, Meibomianitis, or drye patients. So an itch, if someone has an itch, it means allergy. So chronic allergy can be seasonal or perennial. If it's seasonal, it's often it's spring and summertime, and then they get better by autumn. So if they do need treatment, I'll start it in early spring, carry on through spring and summer, and then stop before autumn sets in. They often have this orangey hue to their eyes. The eyes can be watery, and you've got the conjunctival swelling that you can see on there. If you do avert their upper eyelids, so you get a whole variety of papillae. So the moderate ones, the very top pictures, the severe ones with vernal disease, and of course you can also get some corneal changes with advanced allergic eye disease. So the mainstream treatment here is either mast cell stabilizers or antihistamines. We have a lot of products now which are very effective. The old favorite was always sodium chromoglycate, and that needs to go in 4 times a day, but the newer ones are only twice a day, so it's much better for compliance. Often these mast cell stabilizers take about 4 weeks to work, so a patient that has allergy or itch may use them for a week or 2 and say they're not working, but they need to persist for the full effect, which takes a month or so to set in. And new occasions, of course, are much more effective. And the price is also still dropping. So these patients are obviously using something either for 4, 5, or 6 months a year, or all year round. So we need to be a little bit sensitive about the pricing, so that they are obviously paying for this on a regular basis. Is often younger patients. Now you may also see patients that we've treated with glaucoma drops who have allergy to the preservatives. So the drop falls onto the eyelid or skin surface, and they have this red, excoriated, dry skin of the lids. And that obviously involves either changing to a preservative-free drop or another preparation. Local treatment with Vaseline is really good at waterproofing the skin from the effects of the drop. So that does lubricate and waterproof the lid. So if you see this picture, it's because of what we've been giving to patients ourselves. Now, this is a condition that you wouldn't normally manage in primary care at all, but you just put in just to differentiate for something that can be managed in primary care. So this was actually a young girl, I think about 10 years old, presented with a very swollen lid over a couple of days, quite a red eye with pain, reduced vision, I think gone down to counting fingers, and then diplopia. So you can see there the eyes in upgaze. So the left eye is got normal upgaze, but the right eye really isn't moving at all. And often they're systemically unwell. And this is due to a post-septal cellulitis or an abscess in the orbit. The orbit is like a box, so any growth in there, whether it's infection or blood, will cause problems. So this is an abscess in the upper part of the orbit that's affecting the superior rectus and stopping the eye from moving upwards. So that needs an immediate diagnosis, sending to the hospital for a scan and for drainage. The reason I put that in is just to help you differentiate from this picture on the left, which is pre-septal cellulitis. So it's a different kind of redness. The lid is swollen, but the actual eye globe underneath is white with a normal vision and full ocular movements. So that's how you differentiate whether it's a pre-septal or a post-septal cellulitis. So the pre-septal one on the left, that can obviously just be managed with antibiotics in the primary setting, and the patient can be discharged home and this reviewed regularly. So the common thing that will often tends to go to GPs rather than to optometrology is someone with a red eye, sticky eye, gritty eye, and discharge. They'll say that when they wake up in the morning, their lids are stuck together just from the discharge. So this is bacterial conjunctivitis, and the picture on the right is a child with the same. So this is treated with regular cleaning. Well, first of all, you have to reduce the discharge to allow antibiotics to penetrate through the conjunctiva, and then they apply antibiotics. I mean, the gold standard for this is always chloramphenicol that will help with the majority of conjunctivitises. But cleaning is important, as well as other hygiene advice, especially nowadays, and people are more aware of hygiene in the corona era, so they want to use separate towels and take care if they're handling food for the family, just so they don't spread this onto other family contacts. Now, when you come to viral conjunctivitis, it's a little bit different. Often it's bilateral. The big differentiator here is that there's no discharge, but the eyes can be red and watery. So when you make this diagnosis, then obviously there's no treatment for a viral conjunctivitis apart from keeping the lids clean, but also the same hygiene advice applies in separate towels and washing hands and keeping away from other members of the family where the infection can be spread. So when you look at the eyeballs, it's generally red. If you look in the fornix, which is the middle picture, you can see these little raised bubbles, which are follicles full of virus. Occasionally, antiviral can affect the cornea, so you have these corneal infiltrates. We don't always treat this unless the vision is very poor, just because the treatment involves steroids, and once you start steroids for someone with these viral conjunctivitis, they can be on them for a few months because you can't withdraw the steroid very quickly. So if their vision is, say, 6/18 or better, I'll just leave those viral infiltrates to settle by themselves. And they do, they'll take 4 to 8 weeks, something like that, for that to improve. So another kind of infection is where they have these little rash around the lids. Again, it causes a red eye and can be painful. And this is a herpetic rash. And the eye gets red because the virus sheds into the eye. Again, this is about pattern recognition. So if you recognize that that's a hepatic rash, then they can have treatment with acyclovir, which is slightly different from having primary herpes simplex affecting eye, where you have this amoeboid ulcer. So the amoeboid ulcer with herpes simplex needs a topical acyclovir, whereas the skin hepatic infection needs oral acyclovir. So again, another herpes, this is herpes zoster this time, affecting the V2 dermatome of the trigeminal nerve. They have a very red face, or whichever part of the body is involved. Again, this is a systemic condition. It can affect any part of the body, often infects the chest dermatomes, but the face is obviously infected as well, and can look quite horrific, as in this case. So they have a very red skin in that dermatome. They have this rash with discharge and crusting. The real problem to manage is pain afterwards, because they get neuralgia, which can last quite a few months, and it's not amenable to even strong analgesics such as codeine, but it does take time to settle. Now, there is something called Hutchinson's sign. So if you have some of the rash affecting the end of the nose, predicted that 50% of those patients will have uveitis. It doesn't always stand true, but if they do have photophobia, etc., it's worthwhile checking them for uveitis. Then that needs additional treatment. Just because they have a red eye in herpes zoster doesn't mean they need ocular treatment. It's just the virus shedding into the eye, and they just need to keep that clean. So trauma is also very common. So that photograph on the right-hand side, you can see a central epithelial defect, and that would come from having something in the eye, or a finger injury, or from the edge of a paper. So lots of things that can go into the eye cause that. Contact lens wearer perhaps. So they have a watery eye, but a very, very painful eye, and very easy to diagnose. And we just manage that with chlorpenicillin ointment. If they're very painful, then you can pad it, but padding doesn't really speed up the resolution. That abrasion will be better in 24 to 48 hours. So just lubrication antibiotic with chlorpenicillin ointment. You can stain with fluorescein, and if you do, then you get those yellow staining that you see in the bottom of the right picture. But often you can see these abrasions just on a slit lamp. You can see where the edges of the epithelial defect are. So they don't always need fluorescein, but we do use that regularly. So going on to some other red eye things. So someone presents with redness just in the corner of the eye. So this is an Episcleritis, and this is just red in one sector. Although you can have Episcleritis affecting more of the eye, especially in patients with other altering conditions where they get a reactive kind of Episcleritis or conjunctivitis. The way to diagnose it, first of all, it's just in a sector, and it's very superficial, but also when you touch that through the eyelid, it's non-tender. So that doesn't actually need any treatment. That gets better usually within 10 to 14 days, and the patient just needs to be reassured. The reason I put that in is because there's one other condition that needs to go to hospital quite urgently. That is scleritis, and that's quite a different condition altogether. Here, the eye is very, very red, intensely red, and very, very painful, and affects a much greater part of the globe, and the vision is often reduced as well. So that patient on the left needs to go to hospital, have steroid orally. So this is just to differentiate the two. So that's the other condition that needs to be sent to the hospital. So a few other little things. So someone with a red, painful eye with some discharge, the vision is often reduced a little bit, but not drastically, and they may have a history of contact lens wear. So you see on the peripheral cornea there a corneal ulcer with infiltrate in the center. Again, that's something, if it's very small or someone has recurrent ulcers, you can treat them empirically with antibiotics, usually every hour until that starts to improve, then reduce the dosage. But in a new case, it's better for us to see that in the hospital. We take a sample of that and then give the appropriate antibiotic depending on what the sensitivity or growth shows. Because this is a much more severe version of the same. This is where infection is leading to a hypopia, which is that white level in the inferior anterior chamber, and that's a collection of white cells. So that patient definitely needs to go to hospital, have samples taken and intensive antibiotics. So the other patient you'll see in primary care is someone with a painful red eye, but also systemic symptoms such as nausea and vomiting. As optometrists, it's very easy to look at their glasses and see that they're hypermetropic often. And the vision will be down, the pupil will be fixed, semi-dilated, and that's what you see in acute angle closure glaucoma. In mild cases, we can just treat that with agents to reduce the pressure and then send to hospital for iridotomy, but these pretty much always tend to go to hospital because they need to have oral medication to reduce the pressure as well as topical, and then have a iridotomy as soon as possible. And that picture on the left just shows the long-term effects where you have an ischemic iris as well as a cataract from the acute glaucoma. This is something that GPs are a bit loath to diagnose. Someone with circumcorneal injection pain, and they do have photophobia and pain in the eye on accommodation. So this is iritis, and the reason why you get the pain on light accommodation is because the iris is inflamed, and when it myoses in bright light or when you're accommodating, then that causes pain. So patients with recurrent iritis are very sensitive to when their iritis starts. So if someone's had iritis before, they say, I think I'm getting it again, they're almost 100% right. Again, the earlier you treat these patients with their steroids, the actual episode of inflammation is shorter with fewer consequences or sequelae. So on the left-hand side, you see the typical haze in the cornea with the flare. They can have these endothelial cratic precipitates, which is the middle picture. In severe cases, you may get a membrane of inflammation across the pupil. So they may need to have subconjunctival injections of steroids, but certainly very frequent hourly steroids just to get on top of that quickly. So the very last thing is that often we can make a diagnosis of someone with a red eye based on the history that's delivered by a nurse or a GP. And the kind of things to ask about are discharge, photophobia, pain, the vision, the pupil. So these are all the things on the first column on the left-hand side. So discharge is most apparent in someone with a conjunctivitis, so they'll have sticky eye, the lid stuck together, and that could be yellow or green. Photophobia is most marked in iritis, just because of the inflamed iris being painful when it becomes myosed in bright light or accommodation. Pupil is also small in iritis. Pain is most marked in glaucoma, acute glaucoma. The pressure is usually over 48, and in corneal epithelial defects such as abrasion. So the pain is much more in those two conditions than iritis or conjunctivitis. The vision is reduced in mostly in acute glaucoma, a little bit so in iritis, but not so much in conjunctivitis or with epithelial defects. And the pupil can be small in iritis or large and fixed in acute glaucoma. So that's a good way of differentiating different things just based on the history that you're given by a GP, etc. Okay, I might just miss out this last slide, and I think we'll be sending you these perhaps as a PDF if you'd like to see them. And this is just a pathway just to differentiate what can cause a red eye, whether it's unilateral or bilateral, but it's something just to work through later on. So hopefully we're not coming back to this situation where optometry colleagues' practices are closed and patients can't get their regular refractions. Certainly I've had to get some new spectacles recently, so I had to wait until the beginning of June for myself to do that. Good, so that's the end of what I have to say, and then perhaps we can ask you to fill out this poll again. Matt, back to you, and then we can take some questions.
Thank you, Prof. Sadiq. So yeah, well, we had committed to try and keep it to the hour, so we've got just a minute or so just for asking questions. So as you see, we've got the polling question on the slide at the moment. I would ask if you could put your 1, 2, 3 comment into the Q&A box for me. That would be great. Whilst you are doing that, I've just got 1 or 2 questions that I will just pose to you, Prof. Sadiq, if that is okay. So. One question that we have is around the treatment of the corneal abrasion that you mentioned, obviously from chloramphenicol for sort of prophylaxis. What's your opinion on using sort of nighttime ointment for sort of bad corneal abrasion? So just thinking about sort of prevent the recurrent epithelial erosion occurring.
Yeah, so the ones that require that are the ones that are relatively deep, go down to the basement membrane, and they're usually caused by fingernail injuries or paper injuries. So those 2 injuries are the ones that lead to the recurrent corneal erosions. So first of all, the patient needs to be aware that they may have a problem for many months, often 6 to 9 months if they do have a recurrent corneal erosion. So I do give them ointment to use at bedtime, but that's not the only trick. So what I find is that they ask them to put the ointment in. What I suggest is keep it near their bed, under the pillow, on the sideboard, and when they lie down, put the ointment in, then keep the eye closed after that. And if they do get up in the night time to go to the bath, and put some more in. But the other real trick is that often these patients may still break down when they wake up and open their eyes first thing in the morning. So for those patients that find that are a little bit gritty when they first open their eyes, is to have some drops, again, near to them under the pillow or on the sideboard. And what I say to them is that when your alarm goes off in the morning, don't open the eye that's got the corneal erosion. Keep that eye closed, put a little drop in the medial canthus, and let that drain through the eyelid onto the cornea. And after a minute or so, then you slowly open the eye. And that's giving a little bit of lubricant for the to cover the cornea before you open the eyelid. So that's a really good trick for patients that have a little bit of breakdown in the mornings, even though they've been using ointment at bedtime.
Super, thank you. So I said I'd ask a couple of questions. I said when we did want to try and quite strictly keep it to 8 o'clock. It is now 2 minutes past 8. So what I will do is I will ask Scope colleagues to look at collating any questions we've had on the Q&A. And email us out to you along with any further communications that go out to the attendees tonight as well around the slides as you mentioned, and then some of the product information that's been talked about as well. So so Professor Sadiq, thank you very much for that. It's really informative and really useful for those primary care colleagues who are working within primary care managing patients.
Most welcome.
So I think, from myself, thank you very much. As I said earlier on, I hope that this is the beginning to many sort of events that we can pull together with Scope and other industry colleagues. Thank you very much for all of those who attended. So enjoy the rest of your evening.
Good night.
Thank you.